Hi, this is Amr Abdul Gawad from Texas Tech El Paso. We're going to speak today about hip pain in children. This lecture is for pediatrician. So the objectives of this lecture is we want to identify the different causes of hip pain in children and would like to recognize the pathologies that needs urgent intervention and urgent referral for an orthopedic surgeon. A good source of information is this book, which is Pediatric Orthopedic, a handbook for primary care physician, written by myself and Dr. Naga. It will provide you with a concise, all what you need to know information about musculoskeletal conditions in pediatric patients. Let's start with the anatomy of the hip joint. This is a picture for the hip joint from the front. This is a picture for the hip joint from the back. These two pictures are for the bones of the hip joint with taking off all the muscles. The hip joint is a ball and socket joint. It means that the proximal part of the femur, the head of the femur, looks like the ball. The acetabulum of the pelvic bone looks like a socket, and the articulations happen between the head of the femur and the acetabulum. The hip joint is a deep joint. There is lots of muscles that covers the hip joint. These muscles are responsible for the movement of the hip joint. What are the causes of the hip joint pain in children? So the causes can be classified into trauma and mechanical causes, infection and inflammations, vascular causes, tumor causes, and deep pelvic causes for hip pain. Trauma and mechanical cause, these will have a separate lecture that we are going to present later on. This table here will show us the different types within each category. So in the trauma and mechanical cause, there's fractures, dislocation, some cases of slipped capital femoral epiphysis, labral tear, some cases of impingement and muscle sprain. As we said, that trauma and mechanical cause will have a separate lecture that's going to be presented later. Within the infection and inflammation, there is the septic arthritis, means the bacterial infection of the joint, transient synovitis, inflammation of the joint, osteomyelitis of the proximal part of the femur, and inflammatory arthritis. Vascular causes include the Perthes and sickle cell diseases. Extra-articular causes, these are the pelvic causes, appendicitis and psoas abscess and mesenteric adenitis. Tumors of the hip joint like fibrous dysplasia or osteodysteoma. We're going to discuss the more important causes now. So, how do you approach a case with hip pain in children? First, you have to take a good history. Is there a history of a fever or not? This is very important because it will guide us mainly towards inflammation or infection. Was there a recent viral illness? Because this is connected to certain cause like transient synovitis. Is there a history of trauma? That will change our management completely. Is there a knee pain or not? And remember, there is lots of cases of hip pain in children that present as a knee pain. And then lastly, you take a past medical history and family history. Examination, this is the second step in the management of the child with hip pain. First, you have to assess the gait. This is extremely important. You have to see how is the gait. Is the patient able to walk or not? If the patient is not able to walk, that tells you that most probably there is something dangerous going on. It can be a fracture, dislocation, or infection like septic arthritis or osteomyelitis of the proximal femur. The range of motion, you have to assess the range of the motion of the hip and make sure that this motion is coming from the hip joint as not from the pelvis, as we're going to see later on. Deformity, see if this child has a flexion deformity or external rotation deformity. We're going to see some cases of external rotation deformity in slipped capital femoral epiphysis. Muscle atrophy, that tells you that the hip pathology has been going on for a while. The most common group of muscle to be atrophied with a disease of the hip is the abductors or the gluteal muscles. So you will have to examine the child from the back. Extremely important in case of hip pain is to examine the back of the child. Make sure that this pain is not coming from the back, because in cases of back pathology like osteomyelitis of the vertebra or a herniated disc, that can give hip pain that is can be confused with hip pathology. So you have to examine the back very good, and also you have to examine the knee of the child. What imaging modalities do we need in this case? The first and most important is the plain radiographs. There is lots of information that you can get from the plain radiograph, as we are going to see later on when we discuss the different pathologies. Ultrasound is sometimes needed to see if there is effusion or not. Ultrasound guided arthrocentesis, this is an important method of imaging if you would like to assess the effusion that the child has. CT with contrast if you're suspecting proximal femur osteomyelitis. Magnetic resonance imaging also can help you detecting effusion or infection or tumors, and bone scan also can help with detecting infection. So what are the lab studies we need? There is three main lab studies we need to do. CBC with DEF to see if there is a signs of infection or not. ESR is going to be raised in cases of infection or inflammatory arthritis, as well as C-reactive protein. So let's discuss now irritable hip or transient synovitis of the hip, sometimes called toxic synovitis of the hip. This is one of the most common cause of hip pain in young children. So if you have a child 2 to 8 year old with a 2 or 3 days history of hip pain, this should be at the top of your list. So irritable hip, again, is common in a common cause of hip pain in children between 2 to 8 year old. And what is the reason of irritable hip or the transient synovitis? It's a non-specific inflammation of the hip joint. The etiology is unknown. Some people say it may be related to viral infections. Some people say it may be related to mild trauma. What will be the clinical picture? There will be limping. The child will come limping on one side. The range of motion will be painful, especially flexion, internal rotation, and there may be a low-grade fever sometimes. X-rays. When you do an X-ray of these children, they may be normal, or it may be it may show some widening of the hip joint. So if you see, this is an X-ray of the pelvis of a 6-year-old boy with 2 days history of hip pain. If you look closely, you will find that the distance here between the acetabulum and the medial part of the proximal femur on the left side is slightly larger than on the right side. So this indicates that the left hip has some mild effusion. Also, if you do ultrasound or MRI, you will see the same picture of mild effusion of the affected hip. When you do the lab CBC, ESR, and C-reactive protein, this should be normal or mildly elevated. Again, as we said before, there may be a low-grade fever. What is the treatment of this condition? The treatment is very easy. It is rest and non-steroidal. You don't have to refer to an orthopedic surgeon. It's a self-limiting disease. All what we need to do for the child is just rest from activities and non-steroidal anti-inflammatory. Usually these children improve a lot within a few days. Let's discuss now septic arthritis, very important disease that sometimes affects the hip joint. Septic arthritis is bacterial infection of the hip joint. And why it's important? Because it can cause rapid destruction of the hip joint. The enzymes of the bacteria can destroy the cartilage of the hip, so this condition should be treated as soon as possible. It usually affects children less than 5 years old. What is the clinical presentation? The child most probably will have a fever, and important, the child will have ill-looking appearance or toxic-looking appearance, because this is like having an abscess in your hip joint. Focused exam of the hip will show that the hip is in a flexed abducted position. It means that the child is holding his thigh in flexed and abducted position. There will be no range of motion. The child will resist any trial to move the hip joint. X-rays again will show widening of the hip joint. The ultrasound and the MRI will show effusion. As we see here in the MRI, there is marked effusion of the hip joint. The labs, CBC, ESR, and C-reactive protein are all elevated, and blood cultures are positive in about 30 to 50% of cases. So what is the gold standard for the diagnosis? The gold standard is arthrocentesis, and we usually do that ultrasound guided. So we do ultrasound guided aspiration, as we see in this picture, and the fluid that we obtain, we send it for examination, for culture, and for gram stain. The examination of the fluid show that the white blood cell count is more than 50,000 with predominance of polis. The gram stain and the culture will be positive in more than 80% of the cases. What is the treatment for these cases? The treatment is urgent debridement. These children should be sent immediately to orthopedic surgeon once you diagnose them with septic arthritis, because they need urgent debridement of the hip joint to preserve the hip from the toxic effect of the fluid in the hip joint. So let's discuss now how to differentiate between septic arthritis and transient synovitis. This is extremely important because these two conditions can be very similar to each other. So in both cases, you will have a young child coming with hip pain and limping, and when you examine the hip, you will have some limited range of motion. Remember that transient synovitis sometimes have low-grade fever with some mild increase in inflammatory markers. So how to differentiate between them? It's usually the whole clinical picture. So there is not one single parameter that can tell you if this patient has septic arthritis or transient synovitis, but it's the full clinical pictures and lab work. And remember, cases of septic arthritis usually very ill-looking and toxic-looking children, but transient synovitis are usually more active kids with mild limping. So there is 5 parameters that you can depend on to help you to differentiate between septic arthritis and transient synovitis. The temperature, if the child has a fever more than 38.5, this is more with being a septic arthritis. If the white blood cell count in the CBC is more than 12,000, this is more with being a septic arthritis. If the ESR is more than 40, this is more with septic arthritis. If the C-reactive protein is more than 20 per liter, this is also more with septic arthritis. And if the child is completely refusing to put weight, this is also more with septic arthritis. Cases of transient synovitis most probably will have no fever or fever less than 38.5. White blood cell count is usually less than 12,000. ESR and C-reactive protein, even if they are elevated, they are usually less than 40 for the ESR and 20 for the C-reactive protein. And usually these children are able to walk with marked limping, but they are at least able to put some weight on the affected extremity. So let's discuss now the Perthes disease. Perthes disease is avascular necrosis of the head of the femur in a growing child, and the etiology is unknown. It usually occurs in boys between the ages of 4 to 8 years. The pathology is that there will be affection of the blood supply to part of the femoral head. In a skeletally immature child, this will result in collapse of the head, which will occur with time. The clinical presentation will be limping child for a while with hip pain. The parents will bring their child complaining that he has been limping on the hip for a while. And when you examine this child, you will see a flexion deformity. So this is a 5-year-old boy with right hip pain and limping for a few weeks. If you see the child lying on the bed, there is no obvious flexion deformity of the right hip. This is because the child is compensating for this flexion deformity by doing hyperlordosis of his spine. In order for you to obliterate that hyperlordosis, you bend the other hip all the way upward. So we're in this picture, we're bending the left hip all the way up. This took care of his lumbar lordosis, and as soon as the lumbar lordosis is obliterated, you can obviously see that his right hip has about 25 to 30 degree of flexion deformity. If you bend his right hip, you will see that the left hip is still on the bed. That indicates that there is no problem with the left hip. So x-rays of the Perthes disease. Early in the disease process, you will see the subchondral fractures. If you look closely here, there is a faint line in the subchondral bone. This indicates the avascular necrosis had caused weakness of the structure of the femoral head, and later on you will get the collapse of the femoral head at the area of the subchondral fracture. If you get the x-ray of the pelvis few months after the start of the disease, the picture is so obvious. If you compare the right hip here to the left hip, you will see obviously there is a collapse of the femoral head and increased density of the affected side. Compare here the right hip to the left hip, there is obvious change. Here the left hip had collapsed and there is an increased density of the femoral head. This is another X-ray for a child with Perthes disease, frog lateral position. If you compare the right hip to the left hip, you obviously you can see the difference. Here is a collapse of the femoral head of the right side compared to the left side. There is some fragmentation. There is increased density of the femoral head. The treatment depends on the age. These children should be referred to an orthopedic surgeon because the treatment of Perthes disease is very debatable, and there is lots of controversies. However, in general, children less than 6 years old are usually managed conservative. Children who are older than 8 years old are usually treated with surgery. The conservative treatment will be in the form of decreased activity, meaning that the child will avoid PE and sports, and supportive pain management by non-steroidal or acetaminophen in case the child has pain. Remember, this disease process takes between 2 to 3 years, so these children may be out of sports for this amount of time. Now let's discuss slipped capital femoral epiphysis. This is a very important topic because it requires special attention and urgent treatment. The slipped capital femoral epiphysis usually occurs in boys between the age of 11 and 13 years old who present with knee and hip pain. This is extremely important. Remember that 50% of patients with the slipped capital femoral epiphysis can present with knee pain, and this is a referred pain that happen through the anterior branch of the obturator nerve. The obturator nerve supplies both the hip joint and the knee joint. So in children who have a hip pathology, this hip pathology can be referred to the knee through the obturator nerve. The patients will present with limited hip internal rotation. They will walk with an external rotation gait, and it sometimes related to endocrinopathy, as we're going to see later on. As we said, the child will have an externally rotated gait, and this disease can be bilateral. So what is the etiology of the slipped capital femoral epiphysis? Slipped capital femoral epiphysis occurs due to growth plate weakening. So the growth plate of the proximal femur will be weakened and the slippage will start to occur. Most of the cases of slipped capital femoral epiphysis are idiopathic, and there is no obvious cause that can be identified. However, it's sometimes related to endocrinopathy or to renal osteodystrophy or some connective tissue disorders. So what are the endocrine disorders that can give a slipped capital femoral epiphysis? Most common is the hypothyroidism. So most common endocrine disorder that leads to slipped capital femoral epiphysis is the hypothyroidism. Growth hormone disorders and hypogonadism and panhypopituitarism are sometimes associated with the slipped capital femoral epiphysis. Remember that endocrine causes only represent 5% of cases of slipped capital femoral epiphysis, and the vast majority of cases of slipped capital femoral epiphysis are idiopathic. So you don't have to do routine screening for each case of slipped capital femoral epiphysis that comes to you. This is very important because previously hospitalists used to do lots of lab works for patients with slipped capital femoral epiphysis, trying to identify if they have an underlying endocrine disorder or not. However, the recommendation now is, unless you suspect that with the clinical manifestation and other clinical picture, you don't have to run these labs. Another cause of a secondary slipped capital femoral epiphysis is renal osteodystrophy, and it is highest in patients on dialysis getting growth hormone treatment. It may be related to the hyperparathyroidism that this patient have, and it is usually bilateral in about 90% of the cases, and it has a certain type of slippage. So this slippage sometimes does not happen through the physis as usual. It can happen through the metaphysis. So let's discuss now the clinical picture of slipped capital femoral epiphysis. There is obligatory external rotation of the hip with flexion. If you see here, this child has a right hip pain. When you bend the right hip, immediately it goes into external rotation. This is, if you compare this with the left hip has, when you flex it, it does not go into obligatory external rotation. So how can you diagnose slipped capital femoral epiphysis from the X-ray? This is an X-ray of a 12-year-old boy presenting with left hip pain. If you can see from the first look, you may think that this X-ray is normal. However, let's draw something called the Klein's line. So let's start with the right hip. Draw a line across the neck of the hip. And draw a similar line on the left hip. If you can see on the right side, this line intersects part of the femoral head. However, on the left side, this line does not intersect any part of the femoral head. That means that there has been some slippage of the femoral metaphysis in relation to the femoral head. So remember that diagnosis of slipped capital femoral epiphysis is easier on the lateral view. So this is the same patient with the frog lateral view. You can see also if you draw the Klein's line, here it intersects parts of the femoral head on the right side. However, on the left head, it does not intersect any part of the femoral head. What is the treatment of slipped capital femoral epiphysis? It is hospital admission and urgent orthopedic consult to take this patient to surgery. So this is an X-ray of a child, 12-year-old, who has a slipped capital femoral epiphysis on his right side. This child unfortunately was not admitted to the hospital and was asked to follow up at a later day. However, he presented to the emergency room a few days later when he fell down, and you see now how much slippage does he have. The metaphysis here had slipped a lot in relation to his femoral epiphysis. So this child was taken to the OR, gentle close reduction was done, and he was fixed with 2 screws in situ. Let me show you another example of a slipped capital femoral epiphysis. This child has left knee pain, a 13-year-old boy. When x-rays were taken of the left knee, it was normal. However, the left hip shows obvious slippage. Here you can see in the AP, and here in the lateral view you can see how much slippage of the femoral epiphysis in relation to the femoral metaphysis. And if you see closely, actually on the right side, you can see that there is a mild slip here in the AP, also in the lateral. This is very obvious. If you draw a line here from the anterior neck, you will see it is far away from the femoral epiphysis here. So if this is the picture for the child in the OR table, you can see how much external rotation he has bilaterally. Obviously, it's more on his left side. The gentle close reduction was done, and this child was fixed with 2 screws. And here is his clinical picture after the end of the surgery, with a partial correction of his deformity. Remember, the treatment of slipped capital femoral epiphysis is urgent orthopedic consult for urgent surgery. The surgery is done by in situ fixation. Sometimes the surgeon can do gentle close reduction. Orthopedic surgeons don't do a very aggressive close reduction because that can affect the blood supply of the femoral head. Let's discuss another cause of pain in adolescent, which is the femoroacetabular impingement. What does this mean? It means that the neck of the femur abuts against the acetabulum with excessive flexion or internal rotation. And this is there is mainly 2 types of femoroacetabular impingement, or as we call it now, FAI, femoroacetabular impingement. The first type, in which we call cam impingement, it means that the normal groove of the femoral neck is obliterated, and you have a bump here, and this bump will start hitting against the anterior edge of the acetabulum with flexion. The other type of femoroacetabular impingement is called the pincer type, in which you have deepening of the acetabulum than normal. So if you see, the acetabulum usually covers a certain part of the femoral head. In the pincer type, the acetabulum is deeper, so it covers more head. So that makes the femoral neck, even if it's normal, hits the anterior acetabulum at an earlier degree of flexion. And of course, you can always have a mixed type. So usually the femoroacetabular impingement, that usually happens in girls with activities of extreme hip motion, like a dancer, cheerleaders, gymnasts. And the hip pain is usually will be in the anterior and the lateral side of the hip with movement and long time sittings. So again, that shows you the pathology when the hip flexes and internally rotated. If the hip has a normal groove, that will not hit against the acetabulum. However, if there is a bump here, this bump will hit against the acetabulum and the labrum and will cause the pain. So how can you diagnose impingement sign? So again, the child will be complaining of hip pain in the anterior and the lateral part, and this pain happens with activity and sometimes with prolonged sitting. With exam, there will be positive impingement sign. This impingement sign means that the patient has pain with flexion internal rotation. So this is a picture from above for a physician doing the impingement test. So flexion and internal rotation. You may think that this is external rotation because the foot is going outward. However, the foot is going outward, but the hip is going inward. So this is a flexion and internal rotation of the hip, and it should cause pain if the patient has impingement syndrome. X-rays will show the impingement in the lateral view. So this is a lateral view of the hip, and you can see here, instead of having the groove, there is a bump of the anterior part of the femoral neck. MRI would show that more obviously. You can see here, this is an MRI of the femoral neck and head, and instead of having the normal groove, there is a bump here of the anterior part. What is the treatment of femoroacetabular impingement? Usually the first line of treatment is to activity modification. So you try to advise the child to stay away from activities that cause pain, like dancing or cheerleading. If this continues, or if the child insists on continuing on these activities, he can have surgical intervention in the form of either hip arthroscopy or open hip procedure. This is an X-ray of a child who had a hip impingement due to other cause. He had an osteophyte here, and we did an open procedure for him. Surgical dislocation was done and shaving of this part, so you don't see that osteophyte here in the post-operative X-ray. Another cause of a hip pain is infection of the proximal femur, proximal femoral osteomyelitis. The child will present with pictures similar to arthritis. There will be fever, ill appearing. There will be marked limping or refusal to put weight. There will be increased ESR, C-reactive protein, and white blood cell count. MRI will show the osteomyelitis, and the treatment is antibiotic. If no improvement after 36 hours, he may need surgical intervention. Another cause of hip pain is osteoma. This is a benign tumor. It will cause pain worse at night. It usually responds dramatically to non-steroidal anti-inflammatory medication. The X-rays may show the osteoma if it's large. However, in most cases, you will need a CT or bone scan. Treatment is by orthopedic referral. It can be removed either by surgery or by CT guided methods. Another cause of hip pain in children is deep pelvic infection. Cases of deep pelvic infection like mesenteric adenitis or appendicitis or psoas abscess will cause irritation and inflammation of the psoas muscle. The psoas muscle courses very close to the hip capsule and is inserted into the proximal femur. So psoas irritation and inflammation will be transferred to the hip joint. The child will present with hip pain together with lower quadrant abdominal pain. How can you differentiate between hip pain due to hip pathology and those due to pelvic inflammation? If the hip pain is due to the deep pelvic infection, it is related to the psoas spasm. So if you flex the hip beyond 90 degrees, that will relax the psoas muscle, so you will be able to gain more internal and external rotation movement, because the cause of the pain, which psoas spasm, is now less with the relaxation of the psoas muscle. What you can do also is a CT of the pelvis, and that will show you the cause of the hip of the pelvic infection. What are the take-home messages from this lecture? Remember, hip pain in children is a common problem, and there are different pathologies that can cause this pain. These pathologies can be in the hip joint itself, it can be in the pelvis, or it can be referred from the back. You have to take adequate history, exam, and imaging and lab to obtain the diagnosis. And remember that hip pathology can be manifested by knee pain. So if you get a child with a knee pain, don't forget to get an X-ray of the hip and examine this child's hip. Another take-home messages is septic arthritis and slipped capital femoral epiphysis needs urgent attention, and they need urgent orthopedic referral. And remember that intra-pelvic infection can manifest as hip pain. Thank you very much.